Thanks, Caitlin. I'm going to start by saying good morning or good afternoon. I'm in New Mexico, so it's still morning here. And I'm going to go ahead and share the slides. And this is the built environment and population health in urban spaces. I'm with the College of Population Health, and I want to thank you for joining this session. A few housekeeping items. You've had lots of these housekeeping items. So pre and post evaluation, I think Caitlin has emphasized that quite a bit. I also want to make sure that if I say anything and you don't understand it, please raise your hand. I'm watching that. You can put it in the chat. And I also want to talk about this notion of hindsight. You know, hindsight is always 2020. After you prepare the presentation, I always find that I can see the deeper meaning or the purpose of the presentation. And there are two big ideas that I think you should walk away with from this presentation. One is the built environment is a concept that represents the toxicity of a place. What is it about that place that impacts population health? And so the question is, how does place get under the skin to produce illness? And so we'll be looking at that question closely during this presentation. The second idea, and as I've listened to the other presentations, this second idea is really asking you, how do we work on these places? Not on the body as you are used to working on if you're in medical school, but how do you, in your current and future role as a medical practitioner, work on these built environment spaces? So those are the two big ideas that I hope we'll eventually get to. These are our objectives for today. Go into the chat and let me know if you have any questions about any of them. We're going to use, as you saw in the evaluation, a metric of confidence in your ability to achieve these objectives. So we're not measuring your knowledge or your acquisition of knowledge or uptake. And basically, it's how confident are you in your ability to talk about these ideas. I also want to emphasize that I'm interested in clarity. Did the presentation make sense? Were there too many slides? Is there information that could be left out? For this audience, which is largely medical students or medical practitioners, I'm sure it may be heavy on public health theories, and I'd like to know what you think about those theories in this presentation. So again, the agenda is similar to our objectives. I would have to say that this third objective, routes to poor health from the built environment, may be the one that is the most difficult for us to understand or to convey that knowledge to you, but we're going to give it a shot and see if we can get through it.
I'm sorry, I don't want to interrupt. I'm not seeing the slides? I don't know if you're sharing your screen.
I am. I don't know. Let's see. How's that?
Yes, I can see it now. Thank you.
Okay. So I think I'll just go back to this slide. This is the agenda for today. And what I was saying is with regard to this third agenda item, routes to poor health from the built environment. This is probably the most complicated objective for today because it involves public health theories and it may be too content heavy. So please don't hesitate to let me know if this is something that's difficult to grasp. The first objective that we're going to cover is what is the built environment? And so we'll get to that in just a minute. We're going to use qualitative lived experience data that's going to exemplify how minoritized low-income groups experience the built environment that reflects poverty, harm, violence, and unsafe conditions. The reason for using the qualitative data is because it explains these problems best and more vividly. So it aids in quality improvements in how we address these problems. Think of it this way: if you have a better understanding of the experiences of groups that live in these harmful built environments, it's that much easier to think of how to respond and what we should be doing in terms of interventions, policies, and actions. So again, this presentation is heavy on qualitative lived experience evidence. Defining the terms very quickly, you have built environment and you have natural environment. And more today, we're combining these two ideas. But probably about 8 years ago, 10 years ago in the United States, we started talking about the built environment. And the best way to think about the built environment is anything that is made by man. So housing, bike trails, sidewalks, infrastructure, sewage, and pipelines. Another way you can think about the built environment is to ask, what is the natural environment? We're very familiar with the natural environment because we're usually talking about air, land, and water. Today, as I said, you see these terms combined, right? And a lot of this has to do with climate change and how our built environment is changing or responding to the natural environment and the disasters that we see in different regions of the country. More specificity in the terms: neighborhood design and infrastructure. So when you think about the built environment, you can think about it in terms of the design of communities, parks and green space, housing, the affordability of the housing, the quality of the housing. Is there a main street? So in smaller rural cities, you think about a central street and how that is created. Does it induce walking? Are there shops on that street? Are there places where you can both shop and live? In the last 8 years, a lot of effort has been put into redesigning main streets to make them more walkable and livable. Community centers, means of transportation. So these are all built environment features that come under neighborhood design. Then we have sidewalks, water and sewage systems, lighting, and walking and biking trails that have to do with infrastructure. So these are all concepts that we want to think about when we're thinking about the built environment. This next section is an interview with Edie Kramer at University of Minnesota, and she's going to give us 2 key questions we can use to measure built environments. When you hear these 2 key questions, put them in the chat and put in any questions that you have. And now I'm going to play this video. Caitlin, I may need some help making sure that everyone can hear this with the features on Zoom. So it's so nice to meet you, Ivy. What I'd like to do is have you introduce yourself and explain the system that you work in, the institution, and what your area of scholarship is. Why don't we start that way?
Yeah, absolutely. Thank you so much for having me. I'm really delighted to be here and engage in this thought-provoking and essential conversation. So my name is Heidi Kramer-Koseka. I'm a research professional at the University of Minnesota. I've done quite a bit of work in the realm of community engaged research, particularly in rural spaces in South Central Minnesota. And I also do an equal share of work in the metropolitan Twin Cities area in Minnesota, the Minneapolis and St. Paul region. My work there really centers around community partnered fitness interventions and programmatic interventions that take place in parks.
These are two of your publications abstracts that have been made public in the last few years. And so I thought we would start by talking about them. Why don't we talk about mapping community and neighborhood level access to rural physical activity built environments? Well, let me back up first. How do you explain the built environment to people? If you have to explain it, let's say in a public meeting, do you talk about it? How do you talk about it?
Yes, absolutely. So when I think about the built environment, I think about it in a very practical way and a person-centered way. So if we were to ask our neighbor or a colleague about the built environment, we'd really be talking about the environment that's most pertinent to them. So what's available in your neighborhood, right? So what assets are available in your neighborhood? That could be a combination of natural assets and then man-made assets as well. So do you have access to trails in your neighborhoods? Do you have access to sidewalks? Are those sidewalks interconnected, or are they disconnected, where sidewalks and trails are only on one side of the street, or you have to cross a very busy highway to get to and from access points in your neighborhoods, like a school or the grocery store? I'm in the field of physical activity, so I particularly think about the built environment in terms of what's available that can facilitate active behavior. So I might ask somebody, what's available in your neighborhood that you can easily utilize with pedestrian methods, so by walking or riding your bike, or if you're to use public transit or a personal vehicle. So are you able to get to a pool in your neighborhood? Are you able to get to a nearby park? Is there a community center in your neighborhood? And then are there a variety of other public assets in your neighborhood that support health behaviors that are so important and complement physical activity? So for example, do you have a neighborhood grocery store? Are you able to access all the groceries that you need at that store? Or would you have to find another means of transportation to access, say, for example, fresh fruits and vegetables? Do you have a library in your neighborhood? Do you have a place where you can meet with folks and engage in joyful social interaction, things of that nature? So really, if you were to do just a bird's eye view of what's available in your neighborhood, I would ask somebody, please describe to me what you can walk to. And then maybe what could you drive to within 10 minutes that's easily accessible for you and your family?
So can anybody tell me what the two questions are that Edie talked about in her presentation? She gave us two central questions. Does anybody know what those two questions were? So nice to meet you, Heidi. So essentially, Heidi said that what she asked people is, what can you get to within 10 minutes walking or driving? Can you get to a place that affords you opportunities for food that is high quality, affordable, something that your family or that you would eat, and that you would not have to go more than 10 minutes to get to that source of food? Does everybody currently have that opportunity right now?
No,
I can't see the chat right now. I'm trying to get to the chat, but
not everyone does.
Yeah, can somebody tell me a story about that? Either a neighbor, a relative, or do you live in a place where you cannot get access to food within driving 10 minutes or walking 10 minutes?
Where I live is very accessible, but where my brother used to live, his previous house, they were in Indiantown, which is a part of Florida that's kind of like very west of Fort St. Lucie. I don't know if that means anything to anyone that's not familiar to Florida, but it to get to any like gas station stores, anything like that, it was at least a 25-minute drive because it was more so in a very rural part of Florida. So it was not accessible to a lot of necessities.
A lot of the research I do around food security has been in West Virginia and here in New Mexico. And this issue of access to food, and there are 5 A's for food access. Um, it's a huge problem in these environments here that I've studied. I'm originally from Houston, Texas, and in Houston, in that urban area, it's also a problem for individual neighborhoods. They don't have access to grocery stores or quality food. So the contours of what it looks like at each place change, but basically the built environment and what is there in each place can be problematic. The next video is a lived experience video that's going to provide us with evidence of how a couple in West Virginia experience a resource-poor built environment. And I want you to pay attention to what's happening to the couple in this video. And they use a really funny term in the video. I'd like for you to listen for that. But when they use this term, it's funny, but it's actually a really problematic idea for dealing with the built environment.
What are your work hours?
7 to 3:30.
Okay,
In order for me to get to work on time, even her place, the first run would need to be at
fine,
5:30.
okay, because we had to take 3 buses to get here today, and that took 2 hours.
It would take me one bus from her place to the depot. That's, from the depot is only like maybe a mile and a half of a mile work. There actually doesn't, they don't have a bus that runs down to my job.
Into the industrial park, where a lot of people work, and he's not the only person who works there who, has trouble with transportation. Right. Yeah. So have you ever had to miss work because of drives?
I've had to call out several times, that I'm not having to ride. Like I
And
said,
what do they say, how?
they're like, they're not happy about it. Kind of jogged about it the next day when I finally do get to work. Get a reliable piece of transportation, or why didn't you use your Subarus? It's a joke.
That's interesting, I had not heard that before.
It's like, well, on one coworker, he's like, well, you live right there on the rail trail, you could walk. I mean, you walk 11.4 miles
In the dark.
in the dark,
Right.
through the woods.
And he has walked to his job from where I live, which it's really not much closer.
It's not bad. It's like from Margaret Gardens on foot to my job's hour and 54-minute walk. The time you get to work, you're tired, you don't feel like doing nothing. So what do? You leave at 3 a.m. in the morning to get there by 7, and you're like, okay, well, if I leave at 3, I got this much. It's gonna take me almost 2 hours to walk. I'll have an hour to rest. And then one day to work, rest my legs, rest my feet.
So that one, if you couldn't hear it, please let me know. I'm trying to work on how to boost the sound on that. But this couple is really interesting. In West Virginia, in that part in Morgantown, they have something called the rail trail. And the rail trail for middle class people is a source of exercise, biking, running, manifesting their physicality, staying healthy. But for low income people, it's the way they have to get to work sometimes. And so this gentleman actually works at an industrial park site. So that alone is problematic. So this industrial park site. And they don't have transportation. So when he has to get to work, he has to start walking sometimes at between 3 a.m. and 5 a.m. There is no bus service between that time. And so the term is already there, shoebaroos. He says that his friends at work, when he can't get to work, they tell him to use his shoebaroos because he doesn't have money for a Uber to get to work on a daily basis. So you can see how this is problematic in many ways. So it impacts your ability to get a job and keep a job, earn a living wage, support the household, and secure the things that you need. And you find this in all kinds of rural places here in New Mexico, as well as in West Virginia. One other set of videos that I want to use to exemplify structural barriers to population health is these videos, and these are issues, again, with the built environment. And I want you to listen carefully to both the problem with the built environment and then try to think about what health issues can result as a result of these built environment issues.
Good morning. Well, I got a picture of a bus station with a glass out of the back, completely gone. I've taken shelter in this a couple times, but the only problem is when it rains, boy, I tell you, the rain just blows in there bad. And the glass is behind the thing, which is great. They could hopefully reinstall that. That's what I would do. No one comes to fix it. I've reported it at least 4 times. I know other people that report it 2 or 3 times a day, but nothing ever happens. And it's been like this since last winter. It's amazing that that glass is still laying there. Really amazing. But, it's a place to get out of the rain when you're waiting on a bus. There's a lot of elderly people that wait here for this bus. And you know how that goes. Nothing's being done.
Because usually you have to take the bus about 2 hours before your appointment, because there's at least 2 buses involved to getting to the appointments. Some days my 9-year-old, my 10-year-old, sorry, he has anxiety. So like it's an extra workout because you have to convince him it's okay to get on the bus that we have to go. Say for a 10 o'clock appointment, probably about 6:30, just to get 5 kids ready and fed and everything and out the door. It's at the entrance of Bluegrass Village, but it's really not safe, like to stand there and wait for the bus. There's no sidewalks, there's no shelter, there's nothing. You have to stand at the entrance, kind of in the driveway. Yes, yeah. Cars coming in and out of Bluegrass because they're coming off Greenback Road and they don't always slow down. They will just come turning in. So a lot of times I'll have them stand up and back and I'll stand by the road and they know when the bus comes, then they can come forward.
I got home on Thursday and I needed food like on Friday because I wasn't able to be up that long to prepare it for myself. I have it there. but there was no one that I knew that I could call to come and do this because my son lives 210 miles away and my daughter's in Arizona, so she had just left and went home. And I couldn't ask her to turn around and come back, not that many miles and have to fly. Anyway, I called to try to get food, and I was the next Thursday. I called Senior Citizens Kingwood, where the office is, and they had to send somebody to, I guess, interview me. And then after that, I was able to get food, but it took a period of time.
Yeah, so on the west side, I would call it somewhat urban, urban environment. There's not that much green space. There's streets and sidewalks, not perhaps the best place for kids to play. You have to concern yourself with traffic. And more than that, I've heard stories of people saying that gunshots ring out quite often. Sure, when I'm a parent, or even now as a 25-year-old male, I would not always feel comfortable being out in a place where gunshots are always going on. So I think that forces people indoors and more of a sedentary lifestyle because they can't go outside and enjoy that aspect of their community. You run into the problem that you only get to see patients for 15 minutes at a time in a room. That's very safe, and it's this opportunity participating in Code Voices allowed me to see where people live 99% of their life.
So I want to take a minute and have you talk about what problems you saw in the video, and then what kind of health problems that can lead to. So what were the problems that people talked about in any of the videos you saw? And what are the resulting health problems that could result from those built environment problems? Can anybody start us out?
I can start. Some of the problems were safety, safety with transportation as well, access to food, and the issues that it can cause in their health if they don't have a safe living environment that can result in more injuries. If they don't have safe public transportation to get to their appointments, that will or can result in them not going to schedule appointments, not following up with labs or getting refills on medication, which can worsen any conditions that they may have. So those are a couple of examples.
I really liked the video about the bus shelter, and that was a big deal in Morgantown, and it made a lot of the transportation authority people upset when they saw those videos. But not having a bus shelter, for instance, what is that like? What do you think that experience is like? And what happens when you see somebody in your clinic? Do you ask them about those issues? How do you get to these built environment issues when you're screening patients? Do you have a screening tool for the social determinants of health? Anybody? At the VA hospital, they use a tool called ACORN, and they screen for 9 social determinants of health. Dr. Etienne, did I see your microphone come open? Were you going to say something?
Oh, yeah, I was just, yes, thanks. I was just answering the question that, yes, our EMR does have a built-in social determinants of health that they take the patients through it when they first get checked in. and just mark off, various questions.
Thank you for that. Yes, I do know that that's very popular. A lot to have these screening tools, either social workers use them. I don't know if the doctors actually screen for social determinants of health. I think someone else does, and then they use it like a checklist. But again, I want to go back to the bigger idea for this presentation is even though you use a checklist and you find out that the person doesn't have a job, doesn't have an income, doesn't have a car, doesn't have a way to put gas in the car, the question is, what is it that healthcare systems do about these things, or what is it that you would do about them? Let's go back to the presentation. So the next objective in our presentation is to think about why these spaces have historically been low resource built environments or poor built environments. And we're going to use again a series of videos, and we're going to start hypothesizing how unhealthy and structurally violent neighborhoods and the resulting trauma work to cause illness. So start thinking about these routes that the built environment uses to create poor health. And I'll give you a hint early on, there are at least 3 routes by which these built environments get under the skin to produce illness. But let's think first about why we continuously see these poor built environments. Redlining and gentrification are built environment reasons for historically low wealth neighborhoods with minoritized groups. So if you go in the chat, and I think Caitlin can see the chat, let me know about your familiarity with redlining if you already know about it. We're going to cover it on this slide. I'm not going to spend a lot of time going through redlining. I believe a lot of people know what it is. But you can think about redlining and gentrification as the same side of a coin. So on the one hand, you have redlining, and then on the other side of that coin, you have gentrification. So redlining is historical trauma related to being zoned out of spaces in neighborhoods. And redlining is about being forced to live in less than great places. And on the other side of that coin is present day trauma related to being shoved out of the very spaces you were forced to live in when your grandmother or your parents bought that house, right? So there's redlining and then there's gentrification. Let's see. Courtney, you said you were familiar with redlining. Can you talk a little bit about how you know about redlining?
I just took a course in college related to, I think it's like geography and health. And they talked about redlining and how pretty much I just remember a lot from college.
You remember it was bad, right?
Huh?
You just remember it was bad, not a good thing.
I remember it's bad. I remember that we talked a lot about how African Americans and white people will feel differently about the demographics of their community. And so African Americans would be fine with more diverse community versus white Americans would start to move away, and how that affected like the overall economics of different communities over time.
That's a good story because it almost fits in the middle. So there's redlining where our grandparents, parents were forced to live in particular neighborhoods. They could only get loans that would allow them to live in these neighborhoods that sometimes had environmental hazards, were unsafe, could sometimes lead to high rates of crime. And then if they were able to get into middle-class neighborhoods, so this is kind of like in the middle of a timeline, then the majority population left those neighborhoods. thus sending them into decline. And then you have gentrification as the third aspect of that. So I think what we're going to do next is, I had a poll question, and I'll go ahead and ask it, but this is based on an experience I had in a public health class. And I asked the students about gentrification. And the question, and if you put it in the chat, the question is gentrification positive or negative? And you can put positive, negative, or I'm not certain. So can you go into the chat and start answering that question? Let's take about 1 minute to do that. Is gentrification positive, negative, or you're not certain? In the public health class with students who are sometimes under the age of 24, they're either not sure or they say it's positive because of the words gentrification. And this notion of gentrification, the use of the word sounds like you're improving the community. The other issue with gentrification is that you are improving the community, but what is the bad thing that's happening as you're improving the community? And so the students would say, well, they're getting new housing, they're getting bike trails and sidewalks. And so students would say, well, it's a good thing because they're improving the neighborhood. What's the downside of gentrification? Caitlin, you say the way that it's done makes it negative. What happens with gentrification that makes it negative? Anyone?
I think there's a lot of ways that make it negative. I think one is this actually happened to my fiance's great grandma. She lived in a part of Chicago that wasn't the best area, but she owned her house for years, and unfortunately, she couldn't afford the upkeep after a while, and so she kind of essentially got pushed out. They found that corporations, if they want to get the money around, exactly, they'll price people out or they'll kind of report code violations to make you have to fix it. And some people cannot afford to fix all of the things that need to be done on an older home.
Yeah.
So then they ended up having to sell it. And then those developers are able to buy it at a pretty low cost because they're a huge corporation. And then they build it up and they price those homes or apartments way too high for people that live in that area. So then they get relocated and people that can afford it move in. So I feel like that's one aspect that it's bad. It also, I feel, gets rid of like a lot of culture in certain areas because they don't end up putting in those types of restaurants or stores or food. They just make it more of like these artisan things and stuff like that. So that's my take on why it's bad.
Yes, I think that's a great description. The one word we use for that is displacement. So gentrification starts to improve the neighborhood. It does begin to change the structural conditions of the neighborhood. It changes the cultural conditions of the neighborhood. Property values go up, and the people who are long-term residents, long-term business owners cannot afford to live in that neighborhood anymore. This next video is just going to give us an explanation of gentrification. And there are a couple of questions as you watch the video. Discuss gentrification, redlining, and displacement. We've done that. And what happens to those places once minorities live in those spaces with gentrification? Is that usually what happens to those neighborhoods? And keep thinking about the health implications of all of this as well.
Gentrification is constantly being talked about. In the past 10 years, the number of Google searches for the word gentrification has more than doubled, and mentions in the news and in literature have gone up. So people are talking about gentrification, but they often mean different things when they use the term. Gentrification is a process of neighborhood change that includes economic change in a historically disinvested neighborhood by means of real estate investment and new, higher income residents moving in, as well as demographic change, not only in terms of income level, but also in terms of changes in the education level or racial makeup of residents. Gentrification is complex and needs some explaining. To understand it, there are three key things to consider. The historic conditions, especially policies and practices that made communities susceptible to gentrification. The way that central city disinvestment and investment patterns are taking place today as a result of these conditions. And the ways that gentrification impacts communities. Over the last century, many policies and practices have created racialized patterns of disinvestment in city centers that have left low-income communities of color particularly susceptible to gentrification. From the 1930s through the late 60s, standards set by the federal government and carried out by banks explicitly labeled neighborhoods home to predominantly people of color as risky and unfit for investment. This practice, now known as redlining, meant that people of color were denied access to loans that would enable them to buy or repair homes in their neighborhood. Other housing and transportation policies of the mid-20th century fueled the growth of mostly white suburbs and the exodus of capital from urban centers, in a phenomenon often referred to as white flight. Take the GI Bill as an example. The program guaranteed low-cost mortgage loans for returning World War II soldiers, but discrimination limited the extent to which Black veterans were able to purchase homes in the growing suburbs. In fact, the Federal Housing Administration largely required that suburban developers agree to not sell houses to Black people in order for the developers to access these guaranteed loans. Left behind in central city neighborhoods, low-income households and communities of color bore the brunt of highway system expansion and urban renewal programs, which resulted in the mass clearance of homes, businesses, and neighborhood institutions, and set the stage for widespread public and private disinvestment in the decades that followed. In more recent history, the foreclosure crisis also contributed to neighborhood-level vulnerability to gentrification. In low-income communities of color, disproportionate levels of subprime lending resulted in mass foreclosure, leaving those neighborhoods vulnerable to investors seeking to purchase and flip homes in bulk. Today, both people and capital are flooding back into these historically disinvested neighborhoods. One reason new people are moving into these neighborhoods is because of their relative affordability. In many US cities, the rental market has gotten increasingly expensive, and even moderate income earners are on the hunt for lower housing costs. This means that in some places, they are looking at historically disinvested communities, often the same neighborhoods previous generations left behind during the days of white flight. These neighborhoods are often characterized by older historic housing stock that appeals to new residents and close proximity to city centers, where jobs, restaurants, and art spaces are increasingly locating. Cities are also investing in revitalizing some of these neighborhoods, for example, with improved transit access and infrastructure, in part to draw in newcomers. On the ground, gentrification may look like real estate speculation, with investors flipping properties for large profits, as well as high-end development, and landlords looking for higher-paying tenants. Increased investment in neighborhood amenities like transit and parks. Changes in land use, for example, from industrial land to restaurants and storefronts. And changes in the character of the neighborhood.
So that video goes on for about 3 more minutes, and I know our time is getting close. But you can see the process of how these neighborhoods become low resource built environments, how they stay that way over time, and how they haven't changed. So when you look at these neighborhoods and you go back 50 years, and you look at them moving forward in time, we see this perpetuation of low resource built environments. And again, I think the questions for healthcare systems are, how do we do anything about this? And eventually we're going to get to that as we go forward in the presentation. Let's go ahead and move forward. I'm going to share the screen again and go back into the presentation.
As community-run businesses are replaced.
So the next objective that we were going to talk about is, how does the built environment make groups sick? And I told you there were 3 routes by which built environments make people ill. And the central question is, how do these built environments make people ill and get under the skin to produce the illnesses that we see in our data, in our clinics, and in our hospitals? It's an important question, and it was one that was posed to us when we were just starting out in public health and trying to study these places and how they make people sick. We do have 3 objectives left: how the built environment impacts morbidity and mortality, taking account of these 3 routes, strategies to improve resource-built environments, and then we're going to look at some recordings of medical students talking about the built environment and how they would respond to these problems. So, this is probably overwhelming, but let me break down this particular model. And again, understanding how the built environment makes populations sick allows us to figure out where we're going to intervene. Most of the time, when we look at what happens with people and illness, we start at the right side of this model, correct? So this is where we have adverse birth outcomes. This is a model of what happens to women and high infant and maternal death rates. So if you're in medicine, you're really starting here on the right-hand side of this model. But the point of this presentation is that we're trying to start down here on the left side of the model. And so this is where trauma from the built environment comes from, these structural and systems issues. And then as we move from the left to the right, we see that traumatic environments can change behavior. So we get maladaptive behavior. People are more likely to eat in an unhealthy way. People are less likely to exercise when they live in these traumatic built environments. Then we have people who also experience loss of opportunities and resources. So they live in areas where there's not a good education system. They live in areas where there are unsafe neighborhoods, gun violence, unsafe housing, unhealthy housing. So essentially, we have 3 routes by which the built environment makes people sick. First, it changes their behavior. So we get maladaptive behavior. Second, we get loss of opportunities and resources. And then thirdly, in this box in the middle is where it gets under the skin through the central nervous system. And so in medical school, you probably studied the central nervous system and what happens when it experiences stress and trauma. And then you go all the way down here to the right and you start working on medical interventions for poor health, what happens to the body. Does anybody have any comments or questions about this? Where do you think you're doing most of your work right now in medical school when people experience built environments? I'm really curious about this, so let me turn the camera off. When people come out of these built environments, where do you think you're learning how to intervene? What have you learned in medical school so far?
I think it's kind of just like a dependent on like where your rotation is, because some of our rotations are like in the city, some are in like more rural environments. But I think overall it's just the idea of trying to like integrate or like collaborate as much as we can with like social workers and like trying to see, I guess, from that aspect, like what can we, do to help prepare the patient for when they go home. I guess I'm thinking more so like for an inpatient experience. Because I think that's when sometimes it comes up the most for us, not as much on the outpatient experience, but usually when it's inpatient, it's kind of like concerns about how they will be able to kind of follow up with things when they go home.
Yeah, I think that's a good response, Angelique. So more and more what we're seeing in medical schools is that they're pairing up social services with the healthcare experience to try to figure out how to address these unsafe built environments and their impacts on patients. But if you took all those patients and you map them, it turns into not 10 patients, but 150 people living in a population in an enclosed space. And so then the question becomes, what do we do about that enclosed space? not the 10 patients we saw yesterday or the 5 we're going to see next week, right? So again, that's where we're going eventually in this presentation, if I can hurry up and get there. So what can we do to improve resource poor built environments? So in this next section, we're going to hear from an expert who is a community redevelopment expert. And I'm only going to play a part of this interview. But basically, he's talking about government intervention and how we revitalize these neighborhoods. And what you need to be thinking about is, what's the role of the healthcare system in revitalizing these neighborhoods? And if that's even possible. And I can tell you that there are healthcare systems that have gotten involved in community redevelopment.
So thank you and good afternoon, everybody. I'm going to talk to you about community redevelopment in what I would term an ecosystem approach, and a little bit more introduction on me and my organization. I first met Dr. Andress, Lauri, I think about 8 years ago when we were on a statewide committee in Texas looking at social determinants of health. And I had quite an education throughout that process. And I think it is a very good sign that we are beginning to talk urban planners and community developers and health professionals and others about coming at community development in a more holistic way. I think the main aim of our efforts here is to address that adage that your zip code should not determine your longevity or your educational attainment, how much you earn, or your general quality of life. And noting fully that correlation does not equal causation, I'm sad to report that I think your zip code is, in fact, a very good predictor of all of those things. And that is what those of us who are involved in community development are seeking to rectify. And I feel that I must give a disclaimer to this audience. I'm not an academic or a public health professional. So what I'm going to share with you are just my observations and impact opinions with about 40 years experience in urban planning. And I would encourage us to think about community development similar to the way those of us involved in environmental issues might think about restoring broken ecosystems. I'm going to share with you what some of the historical causes of neighborhood disinvestment and decline are, some of which Dr. Andress has already mentioned. Also going to talk about some of the actors, particularly the government and private actors that can share or impart interventions. And then I'm going to close with some of the metrics I think we ought to be using to measure success. So first of all, what is community development? I found this definition on a website that I will encourage you to take a look at because I think it has a lot of information germane to your topic today. But basically, intentional collective actions to improve social, economic, physical, and environmental well-being while preserving valuable aspects of the culture of a particular geographic area. Now, that is no small task. It involves many moving parts. And as I mentioned before, with my educational journey and the merging of health and urban planning, it really is going to take some silo busting and a lot of disciplines that have heretofore been functioning in relative isolation, coming together with more of a multi-sectoral approach, and that begins by dialogue systems perhaps. So I'm going to boil what I consider to be the ecosystem components into a very simplified triangle of interrelated factors. First, obviously, is the community itself, the various stages and stations in life of its members and the challenges they face, as well as pardon the cliche, the social fabric that exists, whether that be expressed through formal institutions or informal networks, and basically how people relate to each other in that setting. The second edge of the triangle is the economy. And I don't want to overemphasize that, but economic characteristics of a community, I think, are also pretty good predictors of health outcomes. So first and foremost, does the community offer jobs, opportunities to derive income, and I would submit even longer term generational wealth building? There's a second factor, I think, that gets underappreciated sometimes in looking at the economy. That's not just the jobs, but what does that local economy yield in terms of the availability of goods and services to its residents, and more on that in a minute. And then finally, environment, I'm speaking really in two tiers on that part. Obviously, we think of the environment as, that which is not human. So green space, air and water quality, presence of toxins, hazardous waste materials, and I would say even just the general aesthetics of the environment. And there's been some research that shows that access to green space and nature is very helpful in the development, particularly of children. So we're talking about environment in terms of green, if you will, and then the built environment, which we also have a lot of ability to influence positively or negatively. So the built environment, of course, includes the structures we live in. It includes the structures we do business in, structures we congregate in, and then the infrastructure that helps connect those things and keep them safe. Those can be things like roads, bridges, water, sewer, flood control, and the like. And so I would submit to you that, as Dr. Andress noted, the interrelatedness of these three things is very important. We can have good jobs available, but they might be in a polluting industry. We could have strong community organizations, but if we don't have basic services or safe sanitary.
So Jeff goes on to talk about redeveloping low-income neighborhoods. I think the main point that we ought to get from that video is that there are other agencies that are working on these problems. And if your healthcare system is not in a relationship with the city government, the county government, city planning groups, land use groups, then you're not really addressing the place where people come from, where these problems are originating. And so generally we think about a task force of some kind that involves the healthcare system, city planning, county planning, and regional planning, because these are the groups that are working on these kinds of issues. We have healthcare systems on the West Coast that have been involved in building housing. Of course, that requires the healthcare system to use its funds for that purpose. Not just health fairs, right? A health fair is great, but if the healthcare system can use its funds to build affordable housing in partnership with a community development organization, then you're doing a much better job in addressing poor built environments. Caitlin, give me a time check, please.
Yeah, about 15 minutes.
Okay.
Housing,
The other way that we can address some of these poor built environments is through community organizing. And community organizing is almost a baseline level at which a healthcare system could operate with community groups to get this work going. So if your healthcare system has, for example, or still has a JEDI office or a DEI office, or even an office of community engagement, then they should be in a relationship with community leaders. And those community leaders should have expressed concern about their neighborhoods, right? So they will have talked about jobs, no transportation, housing that's falling apart for seniors. And so working with community leaders to organize them, understand their problems, work with them as they speak about these issues is important. And this is a part of community organizing. So it's almost a baseline step before you start working with city and county governments. And there, the work gets very in depth into land use planning and neighborhood planning. Has anybody ever been involved in a community organizing activity? I'm looking in the chat to see if anyone has ever been involved in community organizing. So the next step that we're going to take is, Caitlin, you said a board, yes? Oh, so you've been involved with a board in community.
Sorry, no, that was a typo. I meant abroad. I was in a couple of community programs abroad.
Where was that? In what place was that?
In Peru.
Okay.
Yeah, I went with MedLife when I was doing my master's degree, and we did a couple of different things in the community. We ran a couple of clinics where we provided some primary care services and some dental services, and then we like rotated. So a big part of the communities that we worked with was kind of what you referred to, like in the beginning with with accessibility. They live kind of in very mountainous areas and they didn't have stairs.
Yeah.
So like any stairwells leading to their house. So like kids and stuff like that would just kind of scale up the side of these hills and mountains. So we had 3 groups rotating. So on the first day, the group would build like the foundation of the stairs. The second day, lay the concrete, which I was on that day. It was pretty difficult because we had to carry like buckets of cement up. And then on the third day, is kind of just like making it look nice so they can feel very proud of their community and the new addition.
Yeah.
But that program was really great because the the leaders of that community, they have to set it up. Like they have to also contribute. We're not just going in doing it completely for them. We're doing it alongside them. And then we have like a celebration together at the end of the week. So we help them in a different facets in that way.
So I want to address this issue of we're not doing it for them. I think that's important. I also want you to consider that these are big problems. If there's gun violence in the neighborhood, if the houses are falling apart, if there is constant dumping of trash in the neighborhood, if there are drugs in the neighborhood, it's not a matter of doing it for them. It's working alongside them to address the problem. And that means that you've got to bring in larger systems and agencies. And so to tell a community, you've got to do this before we join with you, can sometimes overlook the severity of these problems. We're talking about systems, infrastructure, built environment issues, and those are very complicated kinds of problems. So working alongside them to figure out who else needs to be at the table is important. You had a case study. I don't even know if we have time to go through all of it, but I want to talk about fixing the built environment versus people and their bodies. And I like to put it that way because really, when you get down to the heart of it, we are talking about fixing these neighborhoods, redeveloping them or revitalizing them. And not so much emphasis on their bodies and what they eat, but can they get the food that they need to sustain themselves in a healthy way? So let's see, did people read the case study? Can somebody tell me something from the case study that stood out for you? Anything in the case study that stood out for you? We don't have time to go through all of it at this point. I think we're running out of time. Is it too late for them to access the case study if they did not? How many people read the case study?
I'm trying to open the document.
Okay.
And
So in this case study, it's a family living in a harmful neighborhood in Texas. So it's Texas City, Texas. There actually is a city called Texas City, Texas. And so this family is a mom, a dad, a daughter, and a son. Did anything stand out for you from the case study? What was the neighborhood like that was described in the case study? And, you know, as I listen to you guys, this is not your typical medical case study. So we're not starting with a disease. We're starting with the social determinants of health, which is really about where people live, learn, work, and play, if you want to think about it that way. So where was this family living? Where were they forced to play? And what do they have access to?
Seems like it's a bit of a desolate area, unsafe. Um, yeah, just since people have been like moving out and there's like homelessness and drug deals occurring. So probably it seems like a bit of like a desolate and unsafe area in general. Presumably where they have like food deserts and things like that.
So sometimes they refer to these as brownfields, but this didn't even get a brownfield designation because they didn't force people to move out. It's one of those half-hearted kinds of designations where they continue to let people live in this toxic neighborhood. Some people did move out, others stayed there. But really that was not safe from a physical medical standpoint to live in that area. They did not have walking distance access to a grocery store. They usually, the kids on their way to school could stop at a service station and get food, which generally was high in salt and fat and sugar. Where did the mom work? The mom worked at a large service station that was far away from the house and you had to cross a large highway system to get to her job, right? Now, if you move that case study down, Caitlin, you can see that there are recommendations from many of our health agencies about how people are supposed to live. And the irony of this whole situation is they make these recommendations about how you're supposed to live, but we don't build our neighborhoods so that people can live according to these recommendations. So there's a mismatch there, right? So we're telling people how to live healthily, but they don't build these neighborhoods so that people can do that. All right, I'm going to share screen again, Caitlin. So I'm going to go ahead and close out now thinking about how medical students respond to this information. And I did 2 pilots in West Virginia with 2 sets of medical students. And they were exposed to these built environment neighborhoods. They worked with community leaders. They were given tours of the neighborhood by the community leaders. Then we came back to a session where they engaged in a conversation about the neighborhood. And what I asked them to do was to record a 2-minute video explaining what they saw, what they learned in working with these community leaders, and how it might impact their practice in the future. And so what you're going to hear now are 3 different videos and their experiences with these unsafe built environments.
Hello, my name is Kennedy, and I'm going to be answering question number 2. Why would addressing cultural competency and or medical racism be insufficient to remedy health inequities? So I think what we've been talking about throughout this course is that addressing these issues from the point of patient contact with a provider isn't enough to mitigate these issues or resolve these issues. It has to be done from a level much higher up than that point, where you actually see the disparities manifest themselves into physical ailments or disease. So something that I really enjoyed from Friday's lecture was talking about how infrastructure isn't conducive for everyone. Like we were talking about how in Houston, the roads are not built for people, they're designed for people who have to walk. Which I think that you can see that in many different places that just don't have a lot of infrastructure or public transportation. And this got me thinking about how if you don't have a sound public transportation system, as a lot of rural communities do, and because they're rural, they you know, there's limited access to grocery and doctor's appointments, things like that. And if you don't have a car as well, you're dependent on other people to get places, to transport you places, because there's no public transportation system to fill in these gaps. This is just one small example of how, you know, having a provider have a recognition of these kinds of issues wouldn't be enough to mitigate them in a sense.
So what Kennedy is saying is that she came to understand the unsafe, low resource built environments, and that having a provider in a clinic or a social worker think about how to address these is not enough, basically. So you can give a person a voucher so they can ride a bus, but that's not going to address it at the population level because you have a built environment that has larger problems, right? So that's one of the things that Kennedy is saying. This next video is a group of the students talking. So we had a small focus group at the end of the neighborhood tour, and this is what these students had to say.
Structural competency defined by upstream determinants of health in West Side Charleston. We've spent the past few months examining and discussing a multitude of environmental, cultural, and historical factors that greatly impact the health of individuals and communities. Our society, healthcare system, and government currently address issues from the bottom-up perspective, treating disease primarily through a medical lens rather than addressing the lifestyle causes of disease that are shaped by the environment and policy. Although the medical approach to treatment is essential and should be maintained, much more progress can be made towards the effective and successful treatment and prevention by increasing our understanding of the non-medical determinants of health, how they've been shaped by history, and future directions that can be taken to address such issues. Few lectures that we've had on this topic have been extremely eye-opening and impactful in my perspective, not only as a future healthcare provider, but also as a community member. I was truly shocked by much of the history we learned throughout the sessions, especially the information specific to Charleston, West Virginia, that was shared with us by Pastor Watts. Pastor Watts also spoke with my group about personal healthcare experiences he'd had as an African-American male, which seems rather discriminatory and neglectful to the point of being life-threatening. He even mentioned that it did seem that the poor treatment he received seemed to be a result of implicit bias. It was unintentional. However, the consequences of such are still just as detrimental and severe as those resulting from implicit discrimination based on race. This discussion specifically helped me to understand the mindset that many African Americans and other minority races possess in regards to seeking medical attention and what I can do differently as a future provider.
The history that we've learned throughout the last couple of weeks with this project has been very different from the history that we've been taught. And I think that is one thing that we're all ignorant to that history. We don't know that history. So if we all are aware of that history, then it becomes a common ground that we can have to start to work together to right these wrongs.
In one of our earlier sessions on Zoom, I remember when we talked about like the redlining, I actually like called home and I was telling my mom about that. And I was like, I never knew that that was one of the reasons that a lot of African Americans ended up into the same communities together, segregated. I mean, we all knew about like Jim Crow laws and segregation laws, but like whenever those were illegalized, we came up with new ways of segregating, such as the redlining policies. So I think, yeah, that was one of the, I was really surprised by that. And I actually called him and like told my mom about that. So I think other people knowing that, I think everyone should know things like that, because I think it really does take a lot of the stigma away from how we see certain communities that have higher rates of crime and how that rate of crime is associated with race.
So I think that what we learned from especially that last video is issues of bias and stigma and how they make it more difficult for people to see the harmful built environments. So working on those harmful built environments, starting with awareness, attitudes, bias, stigma, and then figuring out how to network and put together task force that can address them from a structural standpoint or interventions that could be implemented within healthcare systems. I'm going to close out now. I think I've gone over time. Have I, Caitlin?
No, you're okay.
Okay, great. All right, so let's just move into a discussion right now. And can anyone tell me what you heard from the medical students that would change the way you think about your practice and what you would do with these patients? And try to think about it not from an individual level, although I understand that's the way you're trained, but if you have any training at a population level, or how would you even get that started within your system? And we can talk about that. I think that might be helpful. I find that most medical and healthcare systems don't have a route to get out of the healthcare system and into the larger areas where they could be working. Does anybody have experience with that? Or a question about it?
That has to be done.
I know cameras are off. I can't tell if people are on a bathroom break or eating lunch or asleep. You could be asleep. Any comments? Courtney, what are you thinking?
Nothing at the moment.
Thank you for your honesty. What about Sophia?
Can you repeat the question?
Yes, have you heard anything during the presentation that stands out for you? And what would you do differently in your practice based on the presentation?
Something that stood out to me was like um the video of the bus shelter and how in the past like my interactions with medical professionals, like they don't really ask, oh, did you have trouble like getting here, or the accessibility of medical services and how that could be implemented. Yeah.
So does anybody have an idea about how you would begin to tackle just something like bus stops on the route of one of the low resource neighborhoods that frequent your clinics or your emergency room? So around your medical school, there are probably low-income neighborhoods. And if you worked with your school of public health, you could map those neighborhoods. And then you could look at the common problems in those neighborhoods if you look at the social determinants of health. So some of them might be no transportation. And if you really started doing interviews, you might find that there are problems with bus stops. You might find that people don't have access to jobs. So what would you begin to do to tackle that?
I'm trying to do that for a research study, and I'm struggling.
What is the research study, Angelique?
Oh, well, it's looking at physical medicine and rehabilitation providers and that specialize in pelvic pain and their location. There's not that many who do it, but I just want to see where they're located and in relation to like where the most at-need populations may be.
That's a great start. So what you'll probably find out is they're located here, your at-risk populations are here, and that you may need more of those, more routes. They may need more routes so that your high-risk populations who are low income can use their services, maybe, if I understand it correctly. So I'm kind of jumping ahead and projecting. So once you find that out, what do you think your next step would be, Angelique?
I found that out in New York. So they're all located in Manhattan, and there's one on Long Island. So all the boroughs are kind of deserts, and then upstate New York is a complete desert. I guess my next step, I'm not really sure. I know there's a problem. I presented on it saying there's a problem. I wanted to go more national to see how big the problem is, maybe get some more force behind me.
Yeah. So there's several different ways you could begin to tackle that. So one is you could collect more data, but I would advise you to collect qualitative data. So to actually interview people who are experiencing that problem, it's more impactful. So if you have your quantitative data and your qualitative data, you can put them together and it has more of an impact because you're telling their stories. Second, if they're just healthcare people at your table, it's not going to be enough. Anytime you build a table and you're tackling a problem, if they're just healthcare people, that's not enough. Your city health department, I know in New York they call it the Department of Hygiene or something like that. They have an excellent set of units that work on social determinants of health. And I would say someone in your school system and at the Department of Hygiene are already working on these kinds of issues. So I would start asking around or look at the health department website. And I may not quite understand what region you're in. It sounds like you're right in New York City. And the third thing is you've got to get those agencies to say, here's a potential plan, and this is how we can implement that plan. Does it come down to money? What is it that they need to do? And I will tell you that most healthcare systems have the funds set aside to do this kind of work. It's just that they invest it. How they invest it is what the key is. So usually they invest in healthcare fairs. But that's not enough to fix these kinds of problems. So take it step by step. As an individual medical student, you're going to have to build alliances with different groups. I know it sounds big, but